February 20th. And I will begin by doing the roll call and seeing who all is here. So I will start with Dawn, our vice chair. Dawn, have you joined us yet? All right, I do know Dawn is planning to join. Greg Clauser is actually excused today. He may be able to join us at some point during the meeting, but we do know that he has a conflict. Chicky, are you here yet? Doesn't look like Chicky's here yet either. Andy, I see you. Good morning. And Kimberly, I saw your name. I don't see you on video yet. Kimberly, you here?
Yes. I am here. Good morning.
Good morning. All right. Sean Parkman should be joining us today. And I'm not sure I've seen Sean yet either. Sean, are you here? Okay, Sean's not here yet. And Emily, I see you. Welcome.
Yes, thank you.
And Representative Nose, I do not believe he's coming today. We know our legislature is busy in session, so he is also excused. We do not yet have a quorum, so we will not move immediately to approving the minutes. So I do have a couple of announcements. Oh, great, Chicky, you are here. Now we have a quorum. So that is great. And I did want to make a couple of announcements. Sean is not here yet, but I did want to let everyone know. Sean, it looks like you are here now. Sean, you're here.
Hello.
Welcome back.
Thank you.
I want to let everyone know that the legislature has approved Sean for the management vacancy that we have had on the PEBB board for the last several months. So welcome back, Sean. We are happy to see you in your new seat.
Thank you. Appreciate it.
Yeah, so exciting that you're here. And I do have an agenda item change. I want to make sure that we have quorum when we have a vote, which is currently item number 7, the trend rate guarantee. We are going to move that up on the agenda because we know that we have at least one person who has to leave by noon. So we're going to move that right after we have the discussion around the round 1 renewal responses. So it'll go agenda item 1, agenda item 2, agenda item 7, and then so on and so forth through 3, 4, 5, 6, 8, 9, 10. So that's the plan with the agenda change. And I have had a chance to look over the minutes, and I am looking for somebody to make a motion on the January 16th minutes.
Good morning. This is Chicky Flowers. I can make the first motion to approve.
Okay, great. Thank you, Chicky. Do I have a second?
This is Kimberly. I'll second.
All right. Thank you, Kimberly. All right. Dawn, have you joined us yet? Okay. Dawn's still not here. Chicky. Oh,
she'll be
sorry.
Closer to about 10 o'clock.
Oh, okay. Great.
Dawn, yeah.
Thank you for letting me know. So I know Chicky made the motion. Andy, how do you vote?
Approve.
All right, thank you. Kimberly did the second. Sean, how would you like to vote?
I guess I'll abstain. I wasn't here.
Yeah, that's fine. Abstaining makes sense. Emily, how do you vote?
Approve.
All right, thank you. I vote to approve as well, and the motion carries. All right, so we are going to move into the round 1 renewal responses. We've got Emery, Andrew, and Emily presenting from Mercer. So I'm giving it over to you, Andrew. I see you're off mute.
Yes, thank you, Siobhan. Morning, everyone. Glad to be with you today, talking through round 1 renewals. As a reminder, this will be the first of 3 rounds. And so we will be discussing this over the next few months. We've got a decent amount of content here, and so there are certain sections that we're going to go through a little bit more quickly than others. But our goal really is that, by the end of the session today, we're hoping that board members are feeling really grounded in terms of where preliminary 2025 costs are coming in. and how that relates to the 3.4% cost cap, as well as having some discussion around some of the medical and pharmacy proposed plan changes. If we don't get to some of the other sections, dental and vision, some of the other ancillary coverages, that's okay, because again, this is round 1 of 3. And so we'll do our best to watch the clock and sort of manage to those goals in mind. All right, and so with that said, here's our agenda. We'll spend a couple of minutes going through PEBB's vision. We'll review PEBB's self-insured claims experience, which really informs the 2025 cost projections for those self-insured coverages. We'll do a quick recap on the final positions from the 2024 renewals last year. And then we'll get into section 4, which is really where we'd like to spend a lot of our time this morning, going through some of the proposed rate and fee increases, as well as some of the plan designs that we'd like to talk through with you all. Since this is round 1, we don't anticipate any votes or decision making on this, more robust discussion. Please stop us with questions as we're going through. And I think with that, we can move forward into PEBB's vision, strategy, and planning. I know folks are familiar with these 3 slides. Holistically sort of represent PEBB's guiding principles. So with this first one, PEBB's vision for healthcare, which we've got highlighted in magenta. It's good to sort of get regrounded in these, as we're, especially during these renewal meetings, right? Because the board is making decisions on behalf of constituents and being a fiduciary of the plan. And so spending a few moments to talk through these is a good way to sort of set the stage before decisions are made. And so, this slide really articulates PEBB's vision for healthcare at the highest level. And so with these next 3 slides, it sort of gets a little bit narrower as we go through them. But, at the highest level, PEBB's vision for a successful healthcare system includes things like innovative delivery, a focus on health equity and addressing disparities, well-being and prevention, creating informed healthcare consumers, and of course, affordability. Is and has been a big focus for PEBB. So let's jump to the next slide. And again, just stop me if there are any comments, and I know, team, you'll help me if someone raises their hand and I miss it. So this view is the second of 3 of these sort of guiding principle slides. This one is more focused on health equity. This is a framework that collectively we use as we're making decisions, as you all are making decisions on behalf of the plan. And so it's a way for us to center decisions within equity. And so this framework is a living and breathing document. It does get updated annually at least. But this has been a really sort of effective tool to help really center things within equity as board members are considering changes for 2025. And then the third slide, if we could advance to the next one, please, Rose, our PEBB's long-term goals. And so again, this is this sort of us continuing to sort of narrow the focus here. And so these are a little bit more specific than the first 2 slides. And some of those goals include things like focusing on behavioral health, health equity, focusing on whole person, really keeping in mind that this is a diverse population. And so trying to address the needs of a diverse population. And again, around affordability, ensuring a richness of the benefit while maintaining an affordable plan for both employers and employees. All right, I told you I'd go through them quickly. I'm not seeing any questions so far, and so I will hand it off to Emery. We'll take you in a few minutes through the self-insured claims experience.
Thank you, Andrew. So the next few slides kind of just shows the claims experience, which kind of will inform the rate increases that we talk about in the next section. So the first slide shows the 2023 self-insured experience based on the paid basis. So taking a look at statewide, the claims came in about just 321 million. It did end up at about $16 million surplus, and the loss ratio that's below 100%, so that's good at 95.7%. However, please note that that loss ratio does include some funding assessment that was applied. So there's about 1.9% of funding assessment. So the loss ratio, if you just took a look at it without the funding assessment, would actually be closer to about 97.5%. So compared to the year prior, you can see that the loss ratio did increase a bit. And so the claims also did increase a bit for the statewide plan. Next slide, please. For Providence Choice, if you take a look on the right, there is a number in red. There actually was a deficit for Providence Choice, which is like not something that has happened for the Oregon PEB in quite some time. So the claims came in higher than projected. And so the loss ratio was above 100% in this case, and a pretty big increase from 2022. Specialty drugs and outpatient surgery and mental health outpatient services help drive some of this cost in this case. Next slide, please. For MODA, it came in at a very small surplus of about 2.3 million. The loss ratio was 98.8%, but again, there was a funding assessment that was applied, which basically increased essentially what we were projecting, the overall cost. So the loss ratio actually was about 100%. So it came in pretty close to where we expected, or maybe just even slightly worse. So for MODA, the costs, again, a similar story as to Choice. Specialty drugs, inpatient surgery helped cause some of the cost increases, and the increases did happen from 22 to 23 as well. And unfortunately, that does impact our projections for 25. The next two slides are on dental. Oops, let's move back one. Thanks. Dental and then vision. Dental, none are number in red, which is, dental has been running quite well. I don't know, in last 10, 12 years, 15 years. This year actually came in as a deficit. The claims did increase quite a bit compared to prior years. And so, we're pretty used to seeing dental come in at like a couple percent, 3%. It is coming in at over 7% increase for 25. So yes, dental experience has definitely has gotten worse, and it has impacted the self-insured projections moving forward. And then for vision on this next slide, the one plan, I guess, that's running really well. The loss ratio is higher than the year prior, but the costs really haven't been significantly higher compared to the most recent time period. And there was a big drop off during COVID, and it's rebounded some, but it's kind of been pretty flat since. So vision actually is the one plan that's running well overall in terms of self-insured costs. Any questions or comments before we move on? Okay. Next section, please. Taking a look at what happened last year, just kind of ground us to what happened for 24. This is taking a look at the fees for 23 compared to what the preliminary fees were for 24, and then what were the final best and final offers. So this is last year. This is only on fees. So plan design changes like that were made are not shown here. So savings from those plan design changes are actually shown in the appendix. But overall, the fees increased basically, 0 to 2, about 3%, although MODA did provide a rate concession towards the end and saved $210,000 per PEB. MODA Dental also saved about $40,000 compared to where they initially offered. For Kaiser, there were some negotiations that ended up reducing the premiums by $2.7 million. So in total, between the first round and the final, there was about $3 million in savings. Next slide, please. Taking a look at 2025. So we show the plans here, and this first one's the ones that kind of make up the composite rate, with the exception of life insurance. But we show the medical, dental, and vision. We have the admin fee increases in the middle column and then the preliminary rate increases. So that's the cost increases for the claims plus the admin fees compared to where we originally projected them for 24. So taking a look at the admin fees going down, the first one's the statewide plan. Well, statewide and choice, let's take a look at those two. So the admin fees are, Providence proposed a 2.9% increase for the admin fees. And we'll talk about in more detail in their separate section about the admin fees and other changes there. Moving down, Kaiser, the admin fees is baked into the overall preliminary rate increases, so we don't show that there. For MODA, they proposed a 3% for MODA, and that includes 360. For the dental plans, 3.3%. Then we have the two insured dental plans, and then VSPs proposing a rate, keeping the rates flat for the admin fees. But taking a look to the column to the right, preliminary rate increases, unfortunately, these are bigger than where we have been in the past. And we do see a double-digit increase for choice. So for statewide, the claims are increasing 7.5%, or the cost overall projection is about 7.5%. That's pretty close to the trend rate, where we're expecting market trends to be. Medical trends, I think 6.5, and we're saying pharmacy is about 10. So blended, that's pretty close to 7.5. The costs have been increasing pretty steady, but not spiking, kind of like the way choice has. So with choice, with the loss ratio being so big, the rate increases are coming in bigger, 11.5% in this case. That 11.5% increase, we don't show the actual premium rates, but that does take choice above the threshold for a low-cost plan. We're not going to really try to deal with that issue right now, but that's just something to keep in mind as we move forward. We will be updating the rates as we go through round 2 and round 3, and hopefully those will come down. But right now, choice is above that 10% threshold. For Kaiser, they proposed a preliminary rate increase of 7.9%. Their claims actually have been relatively good. I think taking a look on the paid basis, their costs coming in are about 4-5% increases over the prior year, which is lower than the self-insured plans. But overall, their trend rates are similar to where they were last year, and those are higher than what we're projecting for the self-insured plans. And the cost increase is about almost 8% in this case. And this cost increase right now is applied to both the deductible and the HMO plan. Deductible plan would still remain a low-cost plan based on these preliminary rates. For MODA, the rate increase is almost 8%, 7.9. The rates in this case, as mentioned, the costs, some of the mental health and especially drugs are driving some of the cost increases. The cost increase does take MODA or keep MODA above that 10% threshold for a low-cost plan. If you remember, last year they were above that threshold, and the board decided to buy down the rates essentially to get them to that threshold. But this year, right now, the preliminary rates do keep the MODA plan above that 10% threshold. Delta Dental of Oregon is coming in at 7.4%. As shown before, they had a pretty big loss ratio above 100%. The costs are increasing, the claims have been increasing, and so it's a bigger increase than in the past. For Kaiser Dental and Willamette, they're both self-insured plans are coming in a little bit at 3% or just a little bit below. And then VSP, their claims have been lower, and we're projecting actually a rate decrease for 2025 in this case. So overall, the premiums are coming in about almost $1.4 billion for PEBB in total. Parts the growing of PEBB and also the cost increases that are kind of inherent in the medical system today. Any questions or comments? Okay. Next slide. So some of the other plans here, so ASI Flex BHS or Benefit Health Solutions, WebMD, and Weight Watchers. We'll go some additional information later in this presentation, but those are basically rate holds except for BHS. So BHS, a blended rate increase is about 2.9%. This makes up about $2.4 million in total premiums, and they are not part of the composite rate. But more details later in this presentation. Okay, next slide. Taking a look at composite rates. So we do show history from 2015 on. The line to look, I guess, is at the bottom, the 2025 projected, is coming in at about 7.1%. With the medical plans all kind of essentially coming in above 7%. Unfortunately, that does make the composite rate increase quite a bit higher. This is based upon actually the 2025 is based upon the January open enrollment census information, but it is coming in above that 3.4% threshold. There was the buy down last year, about 0.5%, which, you know, without it, would have been a 7.6% increase. Right now, that does put you about almost $47.6 million above that limitation. While, again, we hope, you know, as additional claims come in, we get better understanding of where we expect the premiums to be, and that kind of comes down. But this does put PEB, unfortunately, quite a bit above the limitation, which is a situation we haven't been in for quite a while. Sean.
So I know my question's a big topic, so I'm hoping for just like a gut feeling at this point. But you mentioned when we started a few cost drivers, of which, as I say, that's its whole thing. What are our cost drivers? That's like a year-long exploration. But you mentioned specialty drugs, I think, and I think you
Yes.
also mentioned behavioral health. Did you not?
Yes.
Is that right? Okay.
Yes.
And I know that specialty drugs is like, well, it's a special conversation, so I'm not going to ask about that because it's a thing. When with behavioral health, do you have a sense if that is largely due? Do you have a gut sense of whether that's largely due to increased use, or if that's due largely because of increased acuity in behavioral health? Because we've been, you know, sort of trying to increase usage in some ways on purpose, and then yeah. So do you have a sense of that at this point?
A lot of it, well, I will. A lot of it has to do with increased use, but that could be also an indicator of increased acuity, right? Because if you're going in more frequently for your visits, you know, those needs, you know, you're seeing those maybe once a week versus, you know, once every 2 weeks or every month, or people just needing to get those services. So I would have to dive into the data a little bit more. I would not strike out potentially increased acuity as a driver. But if we're just looking at numbers, it's increased use for the most part. But we can look more into that, Sean.
Ollie, were you planning to chime in on this?
Yeah, thanks. Thanks, Siobhan. Just looking at the plan migration in the right-hand column, looking at the PEPM, which pretty much I think every year's gone down from projected. Is plan migration part of the 2025 PEPM calculation or forecast, Emery?
Yes, it is. It is baked in, unfortunately. So so there's probably some saving. I think there is some savings from that. I don't have the number offhand how much due to migration to the lower cost plans in this case. MODA continues to increase in terms of enrollment, and they are a low cost plan. But it tends to be in March again. There's some more additional shifting as new employees come in. So there might be a little bit of a decrease as we increase as we move on with the time period. But it is baked in, Ollie, already.
Yeah, thank you.
Any other comments or questions? Okay. So with that, we can move on to the first to Andrew and overview of our program.
Thanks, Emery. Just hit on this one real quickly. This is just an overview of the renewing carriers. We've put a little pink star next to those that are either rate guarantee or off calendar year renewals. And so you can see by benefit type which of these vendors we'll be talking about today and next month and the following month. So, okay, this is where we wanted to spend most of our time. We made it relatively quickly, so that's good. So here we've got a more detailed breakdown of the self-insured medical administrative fees being proposed for 2025. And so as Emery mentioned, you can see that Providence is proposing a 2.9% increase to the administrative fee for across both plans. And MODA is proposing a 3% administrative fee for the synergy plans. You will notice that the admin fees are higher for the choice and the MODA synergy plans. Those are medical home plans. They're sort of more highly managed plan types, and so there are additional costs with those. And so that's why you're seeing that monthly fee be a little bit higher than the statewide, which is more of your traditional PPO plan. Any questions on this one before we move forward into some of the plan design considerations? If we could proceed to the next slide, please. All right, and so I'll just sort of orient you to how we've set up these slides, because for the next 6 or so slides, it will follow this format. And so this also might look familiar to what board members saw last year. And so we'll spend some time on each of the 3 medical carriers. The way we have this set up is in that dark blue row across the top. Those are the dollar and percentage increases for 2025 on a status quo basis, so not assuming any changes. That will get updated as we refresh cost projections, negotiate with carriers each month. But that is sort of a static figure across each of these carrier slides. So you'll see that across all the Providence slides, all the MODA slides, et cetera. And so we have included each of these considerations in a row, each of these plan change considerations. We've included some commentary that we'll go through, as well as the annual cost or savings impact on the far right. For some of these, they are still TBD as we continue to have back and forth with the carriers and sort of refine what it is that's being proposed. And so with that said, I'll jump into these first few for Providence. These are both pharmacy benefit changes. The first is, oh, yes.
And Andrew, can you just share, just remind the board of the plan around the GLP-1 drugs, and they don't show up here. Thanks.
Thank you, Siobhan, for that reminder. And so that's correct. We are not including content on GLP-1 drug exclusion in this presentation. Our plan is to bring that forward next month in March. And so at that time, we will have the final CR recommendation on the drug exclusion. We will also have the final analysis from Oregon Medicaid from their P&T committee regarding the clinical evidence, which would be another sort of data point to inform any decision making that PEBB board members make with regards to that drug exclusion for 2025. And so we also have a little bit more time next month, and so we'll be able to really carve out enough time to have a robust discussion. GLP-1s are continuing to change. The landscape is continuing to change. And so there are some new things that we'll want to bring forward and discuss, including some case studies for some other states that have removed the exclusion and how that has played out for them.
Yeah, the text in black just doesn't quite yet.
Sounds like we may need to mute someone. I don't know, Rose, if you have that ability.
Yes, I do.
Okay, thank you. All right. And so with these first 2 plan considerations, these are both on Providence Pharmacy Plan. The first is a proposal to remove the dispense as written benefit. And so the way that the pharmacy benefit works today for both Providence plans if a member can use a brand name drug without any medical necessity review, even for those drugs where there is a generic equivalent. And so the proposal here would be to change how that is managed so that when there is a generic equivalent, the member would need to take that. But there would be a medical necessity exception process for members who maybe can't take, those rare instances when a member can't take a generic equivalent. So there would be a process to accommodate those members who need to be on the brand drug. And so these generics, they are just as effective, just as safe as their brand equivalents. And so helping to steer folks to the generic equivalents is good for the plan. It's also good for the member. The member is going to pay less out of pocket. And so in terms of impacted members, we've included that there in the middle row as well. It's about 350 members who would be impacted by this. There are two different savings figures depending on, if PEBB wants to proceed with this, there's different ways to do it. The first of which is not to allow a prior use exception for any of those 355 impacted members. And so that would yield the greatest savings because those folks are now going to be diverted to the generic equivalents. And so that would reduce plan costs by a little bit over $2 million. If, however, PEBB wants to pursue it, but allow folks who are currently on brands to continue being on those brand drugs without any penalty, that's going to reduce the savings. And so the $250,000 savings associated with that way to administer this change really captures any new prescriptions moving forward. And so I'll pause there and see what questions folks have so far.
Looks like we've got Sean and Kimberly.
I just want to confirm because there's some nuance around prescription brands and then following a prescription process, and I just want to be sure that we're talking about the same thing. So what we're talking about here is literally the same drug using a generic, because there's another scenario which we've gotten lots of feedback about where there are two types of drugs that do similar things, or they are prescribed for the same affliction, but they are different drugs, and one of them's way cheaper. And so oftentimes there are some plans that want to try this drug first before they go to this drug to see if it works. And there's reasons for that. And then there have been situations in the world of healthcare where decisions are made where that person has to like retry the other drug again before they can, and they already know that drug doesn't work because they tried it before, but they keep having to keep trying it. That's different from what we're talking about with this proposal. Is that correct? What we're talking about is when it's the same drug, it's just one's a brand and one's generic. Is that correct?
Yeah, I could take that. Hi, Sean. So yeah, what you're talking about is the difference between what's referred to as therapeutic substitution or step therapy, when there's a requirement for a member to try a different drug, a different chemical product that's maybe lower cost, but in the same therapeutic class. What this is talking about with the DAW is generic substitution. And in all instances, the generic products are approved by the FDA to be equivalent to the branded agents. They have to meet the same level of deviation from the brand as the brand itself has to meet from lot to lot. So it should be minimal disruption. That said, there are some members that really do want the brand name product and will push for that. But as you see, all of the drugs that are listed here that are the top products, there's none of these even that would fall into what sometimes we hear about as limited or narrow therapeutic index drugs, like drugs for maybe seizures, where maybe a small difference from lot to lot can make a big change. All of these are Drugs where the pharmacist can substitute at the counter without even contacting the prescriber, unless the prescriber for some reason has marked it DAW. So what this would do is, if the prescriber does mark it as dispense as written, the pharmacy might need to communicate with the physician to better understand, why does the member need the brand. There are some instances where maybe they're allergic to one of the inactive components, or there's a dye in the generic or something. That's like a less than 1% thing that comes up from time to time, and we have been going back and forth with Providence to make sure that there's some kind of exceptions process available. But this would prevent members from just getting the brand because they want the brand name when there's an equivalent generic available. That answer your question?
That answers my question. Thank you.
Yeah.
Kimberly, did you have a question as well?
Yes, so that you answered a lot of what I was also, so I was trying to figure out just exactly the member side of it. Okay, so if you say 355 members, 50% of which have specifically requested, so of the 355, so there'd be not, it's just what's happening at the pharmacy. They don't have to call, they don't have to do prior authorization, they don't have to do all this stuff with their doctor, right?
So that's between the pharmacy and the doctor. It depends on if the doctor has marked DAW or dispense as written on the prescription, or if the doctor didn't mark anything and the member just asked, hey, can I have the brand? So that's the difference. If the doctor marked the brand is required for some reason, then there might need a prior authorization or something like that to determine if the member is qualified for an exception. I would say in those cases, getting an exception would be very, very rare, and there would need to be some reason as to why the member can't use the generic. And the most common of those is they've got a documented allergy to a dye or an inactive ingredient in the generic.
Thank you.
Just a quick follow-up. I don't want to dwell here for long, but my understanding is there's a little more nuance with biosimilars, which can be a bit more different than the drug it's, comparing to replacing, as opposed to a generic drug, which is just like different concepts. Is that correct? Is that true?
Yep, that's correct. It's a very small number of biosimilars that are considered interchangeable by the FDA. Most biosimilars are actually not interchangeable, and at that case, they wouldn't be part of this DAW
Oh, they wouldn't
benefit.
be part of that. Okay.
This is
Got it.
about generics, not about biosimilars.
Got it.
That's a good clarification.
Okay, thank you.
All right, so I will move us to the next one, which is also pharmacy related. And this one is sort of a clarification more than anything else. And so, oh, sorry, you can stay on the prior slide. It was just the second row on the prior slide. Thank you. And so with this one, hair growth medications are an exclusion on the Providence plans. And so with this change, Providence would like to sort of clarify the language indicating that. And then also introduce an option to allow an exception for members who have alopecia areata, which is a sort of a rare autoimmune disorder. And so if the board wants to allow that exception to cover these drugs for members with that disorder, the cost impact would be negligible. There are, as you can see, only 25 PEBB members within the claims data have that condition, and so it is relatively rare when you consider the tens of thousands of members enrolled in the Providence plans. Don, I see your question. Sarah, are you able to answer that one? Should we just have removed the innovator meds from the DAW row?
So I think it does. We can clarify with Providence. I think it may apply to the interchangeable biosimilars, but it would not apply to the biosimilars that are not considered interchangeable by the FDA. Good clarification.
Thank you, Don. We will get back to you on that one. And so with these hair growth medications, Kaiser does cover them for severe AA, MODA does not. And so depending on what direction the board wants to go, we might at some point next month or the following month just ensure that we're striving towards consistency across the plans. But I'll pause there and see if anyone has any questions on this one. Okay, we will move to the next slide then. Still sticking with pharmacy for Providence, but this one, Providence has proposed to update the value list of medications. And so the value list within the formulary, this was a list of drugs that was created by PEBB many years ago to essentially try to remove a financial barrier for members with certain chronic conditions. And so the drugs within the value tier are typically generics, and they are offered to members at no cost. So again, removing that barrier for folks with ongoing medication needs to address their chronic conditions. There would be a cost associated with updating the value list. Some drugs would be added, some would be removed. Generally speaking, it is good plan maintenance to update formularies, whether it's value tier or other tiers within the formulary. And so we would tend to recommend this one. For those, we've got the impact list down below. You can see the number of drug entities being added, as well as those being removed, as well as the corresponding member impact. And so for those drugs that are being removed, proposed to be removed from the value tier, those drugs would move to the generic tier. And so they're not falling off the formulary altogether. They're being sort of reclassified as a generic drug, which has an associated $20 copay with it. And so I will pause there and see what questions folks have. Sean.
Yeah, I mean, I guess, the devil's in the details on this sort of thing. Not to say, no or anything like that. It was just, I guess I would want to know a little more about the process by which we're coming to it. Totally makes sense that we'd want to update it. We haven't updated it in a while. That makes sense. I'm not objecting to the idea, but just curious, like how we're choosing which things come off, which things come on, because if we're, for example, there's a drug that's fairly effective and it's generic and therefore cheaper, and we're replacing it with a more expensive drug, then that might not be, that'd just be something to look at. So I don't know, just like a general question. We got some process we don't have to sort out right now, but just something to think about.
Yeah, so I think this is done through the carrier's P&T, pharmacy and therapeutics process. So they have a group of clinicians that meets and reviews as part of their formulary process, reviews the products that are on the market, the latest clinical guidelines, and based on that information, they're making these adjustments. So for example, some of the changes like coverage of medication to prevent blood clots. I think there's been some updates to the clinical guidelines in the last few years. And so they're just incorporating some of those newer products into the value list.
Yeah, and this is Gina, pharmacist from Providence Health Plan. I was going to also mention that we don't remove any medications in the categories. So for example, we look at the member impact and ensure that we have medications that are highly used for mental health disorders, blood pressure, cholesterol, all the most common medications. So these medications specifically that are being looked at to remove are medications that have not been really utilized by the PEBB members and are kind of medications that, maybe 10 years ago were really popular to use. But now, with the change in evidence and the change in patterns kind of in use, and there's also the ability to grandfather any members who have been on these therapies to ensure that there is no, to ease the members' way as well.
I will thank you for that detail, Gina. I will add too that generally with formulary updates, these are handled by the carriers. I think in this instance, because it's been a number of years and this was a PEB created list of drugs, is why Providence is bringing it forward, just to ensure that the board is in agreement that there should be some regular cadence of updating this list. And so a little bit unusual. Typically we wouldn't bring sort of ongoing business formulary changes to the board, but did want to carve out some time to talk about this one since it's a little bit unique. Okay, in the interest of time, I think we've got about 5 minutes, so let's keep going. This is the final Providence slide, and then we'll get into Moda and Kaiser. Okay, and so with this first one around fertility benefit and expansions, these are recommendations that came from an analysis that Mercer did in 23. It was an inclusive benefits gap analysis where we looked at best practices within fertility benefits and identified some recommendations. And so you'll see this one, a category similar to this one on the Moda and Kaiser slides. The costs for these benefit enhancements are negligible. The first is around removing exclusions for people who've undergone voluntary sterilization. And the second is around covering medically necessary cryopreservation for any member undergoing gender-affirming treatment. I'll go through all three of these and then I'll pause for questions. And the next one is around facial electrolysis. You might remember this one from last year, board members. You had voted last year to expand coverage for facial electrolysis for members with hirsutism with the diagnosis of polycystic ovarian syndrome. And so this consideration here takes that coverage expansion a little bit farther and just opens it up to all members with the diagnosis of hirsutism. And so this is one of those items where the cost is TBD. And then the third benefit we've talked about a little bit over the months, and that's around the doula benefit. Lots of reasons to want doulas to be a part of the network. Better member experience, better health outcomes, less invasive interventions during the birthing process. And so there are two plan design options here. This is another one, kind of like the GLP-1 drugs, where I think we're going to have the CR recommendation in March. And ultimately this is the PEB board's decision, but nonetheless that will be a good another source to consider as you're considering this benefit enhancement. Okay, I will pause there and see if we have any questions so far on this slide. Okay, let's move forward to Moda. Oh, was there a question? Thought I might have heard something. Maybe I'm just hearing things. Okay. All right. And so with this first one for Moda, they have proposed attributing members in a different way. So each member who's enrolled in the Moda plan has to have a designated PCP 360. It is a medical home plan. It's the more highly managed plan that we talked about when we were on the ASO fee slide. And so Moda is proposing changing how members are attributed. So instead of being attributed to an individual primary care provider, members would be attributed at the clinic level. And so in so doing, it would reduce some administrative burdens when that PCP leaves the clinic. And so the most common reason for that is the PCP retires. And then the member all of a sudden is not attributed to a clinic or a PCP. Or in some instances that an individual practitioner will drop from the network altogether, which again creates an administrative burden for the plan and for the member. And so we don't really have any concerns with this change on our end based on the review and discussion we've had with Moda. It does create a little bit of a better experience from a capitation perspective for the clinics as well. And it's less disruptive for members when there are those network changes that are impacting them. So I'll pause there and see what questions there are. Okay, I'll go through the next one while folks are noodling that. And then the next proposed change is to consider the addition of Teladoc as a virtual PCP 360. And so Teladoc, other vendors in this space, have been moving in this direction and sort of enhancing the services that they offer beyond, ER avoidance and urgent care. And so, the intent here would be to remove some barriers for folks who maybe, geographically based on where they are, they've got a really long drive to get to a PCP 360, brick and mortar provider, because the way the eligibility is set up today for MOTA is by county. So there are going to be instances where there's a PEBB member at one end of the county and the brick and mortar PCP 360 at the other end with, several hour drive potentially in between. It also would support folks with other sort of mobility issues as well. And so this is one where, we've had some back and forth with MOTA. We are continuing to do that and evaluate it. It's really important with a virtual primary care solution like this to ensure that it's fitting well within the ecosystem. Referrals to specialists are being handled appropriately. And so there is a decent amount to unpack with this one. And it would be, it would definitely be a change from the current arrangement. And I see, Sean, that you have a question. And so I will pause. And Sean, if you want to go ahead.
So as the newest member of PEBB board, you may just have to remind me a couple details. So right now, MOTA doesn't have a telehealth option. Is that right?
There is one. It's a Cirrus MD. And so Cirrus MD also offers virtual primary care. And so that is one of the questions that we're working through with MOTA to understand why Teladoc is the preferred vendor for this solution. And so there are potentially some redundancies. In this proposed arrangement, Cirrus would not be a PCP 360. But both Cirrus and Teladoc could be doing sort of the ER avoidance urgent care support. And so it's a good question.
I mean, I guess as you're following up, it's like if they're folding in some behind the scenes capacity, this or that for, telehealth, I don't see one, why we would need to approve it, and two, why that would need to cost us more. Do you know what I mean? Like if that's just what they're doing, this is what they're doing,
Yeah. Could be cost. Yeah, it could be cost neutral. I'm not sure. But yeah, that would definitely be one of the pieces that we'll be following up on. Yes, Don.
How does the change in the member attribution from individual PCP to clinic level impact the relationship with an individual PCP? As a PCP, as a family doc, I want to know that when my patients call the clinic, they're going to be scheduled to see me and not my friends over there who are going to have to get to know them. Is there like a sub assignment within a clinic so that if I'm not available for whatever reason, they default to the clinic as a PCP, but if I am available, then they see me consistently? Or is it just clinic level? That relationship, that authentic relationship, is part of the secret sauce of why primary care works and can work. And it's important to me to see that protected. And I trust that there's a plan for that.
Yeah, I can. Yeah, go ahead. Yeah, go ahead, Erica.
I can speak to that really quickly, Dawn. It will not actually change the member experience at all with the provider. So today, when members go to a clinic, they're already establishing that relationship with the specific provider. And even today, with the attribution at the specific PCP level, members are still able to see other primary care providers within that clinic. So for example, they have their main PCP, but let's say they need to do a same day appointment, and so they end up with a different provider because they had availability that day. It's still, the member experience and the way the claims pay is still exactly the same. By changing it to the clinic level, what it's actually going to do is really just, one, make it easier for members to be able to select the clinic versus having to go through and find their specific provider at that specific location, which can be confusing for members. And then in addition, it cuts down on members having to change providers, because a lot of times when a provider will retire or leave a clinic, the majority of the time those members will go to a different provider within that clinic. So when that happens, they don't have to go in and select a different provider, and then it causes it and doesn't cause confusion for them. So that's primarily the reason. It's really just for members' confusion, but it doesn't actually change the experience for the member at all.
Thank you.
Looks like Emily also has a question.
Yeah, thank you so much. I really appreciate the effort to deal with transportation challenges that our members have. Andrew, like you were saying, sometimes cutting down on several hours drive within a provider network area. I also know that the digital divide is a real thing for our members. And, you know, internet access is not consistent across our 36 counties, especially in some of the rural areas and, you know, the Indian reservations, where other folks, immigrant and refugees, are working. And so I don't know how to articulate this question. I mean, I know that like there's the intent and then the actual impact of like trying to provide access, but then does it actually work? And then also I know the federal government under President Biden's administration is like Oregon is due to receive resources to increase broadband. And so I just don't know, like timing wise, like when is that going to be operationalized as well to improve internet access for Oregonians or people of Oregon. And so that's just a question that I have. I also had brought up at the last meeting for behavioral health issues where several of our members are turning towards, you know, telemedicine. There's still a need for mental health providers to get like the vitals of the folks so that they can prescribe medication specific to their, you know, their weights and things like that. And so also just wanted to make sure we're thinking about that as well.
Yeah, and one comment I just want to add first, I just want to say I completely agree with you on the broadband issue. It is really great to have these digital point solutions, which can provide additional access for a lot of our members, but understanding that there are people in parts of the state who do struggle with access to broadband. And you're completely right that some of these solutions will not work as easily for them as people who do have sufficient access to broadband. The one thing I do want to point out, and this will respond to your vitals question, the PCP, virtual PCP solution that we're proposing is very different than an urgent care, which is like the CirrusMD, where the CirrusMD is really to help divert ED utilization. It is to help members when they have an urgent need to help with something and keep them from needing to go to the ED. With the Teladoc primary care solution, it is completely different. It is an actual established relationship with a primary care provider who manages and coordinates their care. And they do have ways that they send devices to the members to be able to check those vitals, and then also have referral patterns in place to get members to a lab for when labs are needed. And I want to stress, and Andrew, I'm sure we'll be having follow-up conversations about Teladoc to provide even more information about it, but it is a comprehensive solution to primary care and not a virtual urgent care.
Thank you. Thank you for that helpful clarification. That's good to know.
Christy, I see you have your hand up.
I just wanted to say that the health equity work group is we have done a preliminary screening of Teladoc with the health equity screening tool, and we do have some questions out, I think, to MODA in regards to some of these equity questions, so that we could understand it a little bit more. So more to come.
Thank you for that, Christy. Appreciate that. Siobhan, are we okay timing wise if we go through like 3 more slides?
Yeah, why don't you go through the MODA and Kaiser and then
Okay.
and not the dental and so forth. Thanks.
Sounds good. Thank you. Okay, I think we can advance to the next slide, please. Another proposal being proposed is to expand nutritional therapy more broadly to the membership. And so today, nutrition therapy is covered in sort of select circumstances. So for members who have a diagnosis of diabetes or diagnosis of an eating disorder diagnosis. And so the proposal here would be to just expand it without sort of that medical necessity review, utilization management that requires certain diagnoses. There are registered dietitians within the network today, and MODA has noted a negligible impact from a claims cost perspective on that one. This one also, sort of hangs with the GLP-1 drug exclusion topic more broadly. So it is another one that we can continue talking about in the coming months, but I'll go through these real quickly and then I'll pause since I know we're tight on time. The doula benefit. So this one we've talked about a little bit already. The fertility benefit expansion. Again, this is the result of recommendations from an analysis that was done, identifying gaps in the benefit. These are a little bit different. Each of the plans has a little bit of a different flavor in terms of the recommendations that were made. And again, the exercise of doing that gap analysis was going really deep on the benefit. And so that's why there are some slight differences between how the plans are administering the fertility benefit, hence the slightly different recommendations here. This one does have for these 3 additions, it does have a 0 to 0.1% increase to claims cost. And then I'll go through this final one, and then again, I'll pause and make sure that folks are getting their questions and comments made. This program, the Costco 6 for 6 program, is a pharmacy program and would be, it would make value tier drugs available to members a 6-month supply from Costco. The value tier drugs, again, are those that are generally generics, no cost share to the member, intended to address chronic conditions. And so today, MODA members can get a maximum of a 90-day supply, so 3 months. And so this would be sort of a convenience thing for those members who are close to a Costco. And it doesn't require Costco membership, but you could get a 6-month supply as opposed to the 3-month that's available today. These are generally lower cost drugs, and so there's not really a cost impact to the plan per se. It's more about convenience for members who again are close to a Costco and want to be getting their drugs there in a longer supply. They'd be able to do that.
Just real quick clarification, not all of the drugs that are on the value tier are part of the 6 for 6 program. It's a subset, but all of the drugs that are part of the 6 for 6 program are on the value tier. It's kind of a limited set of lower cost drugs that are available through Costco where members can get 6 months.
Thank you, Sarah. Appreciate that. Okay, let's advance to the next slide. This one is a little bit of a work in progress in the sense that we've had some back and forth with Kaiser on this first one around gender affirming care, and so together Mercer and Kaiser are still working through this one, and so the cost impact and what's covered today, those discussions are ongoing. Kaiser has communicated that when medically necessary, they do cover these items, these gender affirming care services. But the cost impact in terms of if that's an additional cost for 25 or if those are being captured today based on how the services and claims are flowing, that's the piece that is still TBD. The doula benefit we have talked about, and the fertility benefit expansion specific to the Kaiser plans is noted there. Coverage of cryopreservation storage, coverage of medically necessary cryopreservation for members undergoing gender affirming treatment. Another correction to make in our back and forth with Kaiser. So the fertility benefits are available for dependents. There was a wording update that was made in one of the Kaiser handbooks that indicated that it was not, but that was not how the plan was being administered. It was being administered with coverage for dependents. And so that wording update has been made. Sorry for talking so fast. I will pause, see what questions folks have. This is the last of the medical plan design consideration slides. And so I'll pause for questions, and then maybe I'll just wrap with a couple of comments on next steps before moving on to the next agenda item. Okay, so thank you, everyone. In terms of next steps, like I said, this is round one. We will be back next month. At that time, cost projections will be updated. We'll have additional information on some of these plan design considerations. Yes, Sean, I see you have your hand up.
I didn't mean to cut you off mid-sentence there.
That's okay.
So I guess in like overall comment, I guess I'm a little disappointed in what I perceive as kind of like a lack of creativity on the plans, and I guess I'm asking for some thoughts around some suggestions, some creativity around some cost savings that don't erode benefits or shift costs, right? So just some different ways of doing business suggestions that could be on this list of like, we could do it differently like this. And I haven't kind of seen much of that in this. So I'm asking for that. So for example, can there be an adjustment within certain systems regarding physician referrals to lower sites of care, cost of care sites? Is that an option? Can there be integrating doulas into more of a core care team or something instead of an add-on? Setting some system expectations for prescribing physicians to actively set up their members on mail order pharmaceuticals rather than sending them kind of like if they're on a long-term maintenance drug or something. I'm just spitballing, I'm just throwing stuff out, but I'm just like, just some creative ideas about like, we could change some systems on our side in order to actually do some cost savings that, would take a little bit of elbow grease in the beginning, but over the year it would save some money. And I'm just kind of looking for that sort of creative thoughts. We may not do everything, but at least people are thinking, and that's all I'm asking for.
Yeah, I think that's well said, especially, now that we know where the preliminary cost position is relative to the cap, that will be important in the coming months. I think, Emily, I think you had your hand up first, and then Ali.
Yeah, I just wholeheartedly agree with that, what Sean was sharing. I feel like we have some unique opportunities in Oregon, just some incredible assets to do like, I don't know, more naturopathic or alternative health and healing that's evidence-based. I'm just reflecting, I think I did in a previous meeting as well, my mother who just had the stroke last year, and just how well she's doing today because she was able to get timely acupuncture treatments and timely massage therapy, and then also timely family mental health counseling through EAP. And so, things like that wouldn't cost us a lot, but could be really effective, and especially for people who believe or are comfortable with those types of healing practices. Maybe it's not for everyone, but for the folks that are, and just, a reminder that the Asian American community has increased dramatically in Oregon, with at least 25% increase in 34 of the 36 counties and over 100% increase in 2 central Oregon counties and 60% increase in Clackamas, where I live, but then other counties that already have high levels of Asian Americans.
Yeah, thank you for those comments, Emily. Definitely appreciate that, and appreciate your use of the word timely several times, because that's so important. Any other questions or comments along those lines, or other lines for that matter? Okay, so in March, I think we will have, Damien, I want to say we have an hour and a half on the books to go through round 2. And so we'll definitely be discussing some of these topics in more detail and bringing forward some additional stuff. With that said, thanks for hanging with us as we went through sort of quickly, and we will pick up with some of the other benefits in March as well, dental and vision, some of the other ancillary coverages, and talk through those as well.
Great. Well, thank you. And so as I let folks know at the beginning, we are moving an agenda item up so that we have a quorum for a vote. And this is the discussion around the trend rate guarantee. Margaret and Emery are going to be sharing this information with us. So I'm going to turn it over to the two of you.
Yeah. Thank you so much, Chair Martin and members of the board. Good to be here. Just to note, so this is attachment 6. It is actually slide or page 107 of the PDF document. So the big, I think 140 plus page PDF that went out, if you go ahead to slide 107, we will be there. And there we go. Oh, and actually we can go one more. Take us onto the first slide. Okay, so as Siobhan mentioned, this agenda item is related to closeout and settlement of some provisions of PEBB's 2022 plan year contract. As most PEBB board members probably recall, each of our medical carriers has 15% of plan administrative fees at risk for various performance guarantees, specifically 5% each for administrative measures, clinical measures. These are HEDIS, generally outcome and quality of care measures. And then the remaining 5% of those fees at risk are specifically for a trend guarantee requiring carriers to keep per member per month annual year-over-year cost growth at 3.4% or better. So in terms of settlement for the 2022 contract year, all carriers met the administrative and clinical guarantees. However, all 3 of our carriers failed to meet the 3.4% trend guarantee. And the way the guarantee is structured in contract is that there's a bit of a corridor. Carriers retain the entire 5% of fees at risk if they come in at 3.4% or better. If they have per member per month year-over-year cost growth in the 3.4 to 4.0% range, there's a split. So 2.5% of those fees at risk come back to PEBB and 2.5% are retained by carriers. And then if the measured cost growth is greater than 4%, they return the entire 5% of fees at risk to PEBB. And so all 3 of our carriers did exceed that upper level where all 5% of fees at risk are due back to the program. As you can see in the table on the right-hand side of this slide, it shows the breakdown of dollar amount in terms of what's that equates to. I want to just call out one small correction here. For the Kaiser number, that number is actually $1,000 off on this slide. It should be $528,617, bringing the total line at the bottom to $2,310,451. So just a $1,000 discrepancy there, and we will get that corrected for the record as well. And so what we're asking for your decision on today is specifically how to settle the penalties is up to the discretion of the board. Rose, if you could go forward to the next slide. So staff and Mercer have identified a couple of options around settlement. I'm going to jump right down to the bottom where we note the recommendation with the star, specifically to use those funds to offset 2025 rates. That would involve essentially for Kaiser, it'd be a direct premium reduction based on the final renewal negotiation. With those fees at risk offsetting. For MODA and Providence, it would essentially be, it could be used as sort of a buy down of the premium rate so that those penalties, fees would go to the stabilization fund to be used, in final rate development. So in terms of advantages, this helps move us toward achieving that 3.4% annual cost growth cap, and also avoid or serve as an offset to benefit reductions. Emery, keep me honest here. I believe that 2.3 million is right in the neighborhood of about 0.2%.
Yes.
On the overall.
It is.
Okay, so
yeah, so it helps, but we are 47 million above, so it gets you to about 45 million in this case. So there still needs to be other changes that to meet that 3.4%.
Yeah, thank you. And so in terms of other options, we did identify a couple of others. One would be just a direct payment to reserve fund without sort of any specification of what the funds would be for, and then the money would be in the stabilization fund and usable consistent with the statute that governs that fund. Another option we identified was around potentially using funding to improve benefits aligned with the goals to promote, healthy behaviors, potential opportunities to use funding for wellness programs. Just to note some of the cons there, because this is sort of a one-time funding related to this particular penalty settlement, it doesn't really address any sort of sustainability or long-term cost needs for any new programming that could theoretically be launched using this money. And then also, may factor in a need for limitation to if we were to use the funds to spend on new programming. So hence, I think as you'll note, we have identified the sort of what we would recommend as a path forward for the board in terms of settlement. I'm happy to take any questions and invite board discussion.
So as Margaret noted, the penalties are essentially 5% of admin across the board. In terms of trying to meet low cost plan thresholds, since it is kind of consistent, it's not really going to adjust that much. It's just going to reduce all of the plans rates by essentially that portion of the overall cost, about 0.2% or 0.3%.
All right. Well, thank you, Margaret and Emery. Want to make sure board members' questions are answered around this, and I just want to comment. Just underscoring Sean's most recent comments after the round one renewal rates. We are definitely going to need to see some changes. Hopefully, all of our carriers will come with ideas around how to streamline how folks are receiving benefits, any ways we can save on the overall costs. And this offsetting the 2025 rates, as you are both saying, that's 0.2%, and every 0.2 counts. So since we do have the requirement to meet the 3.4%. So do folks have any questions? And if not, is anyone willing to make a motion on the direction we should head? Chicky, go ahead.
So I just noticed in the bottom under Mercer's recommendation, we do not have anything listed out for cons. I just want to verify that there's actually no cons to this recommendation.
When we were thinking about it, we really didn't really identify any obvious ones. I don't know. I'll try to think any real quick. But none so far. I don't know, Andrew or Ollie or Margaret, if you have any additional comments on that.
No, I concur, Emery. We didn't identify any immediate cons. It seemed like a fairly straightforward approach. And Andrew had his hand up for a second, so.
Was trying to send a thumbs up so you can disregard.
Gotcha. Great, thank you. Good question.
Thank you.
All right. Thank you. Do we have a motion?
Since there are no cons and it sounds like a great idea, I move to approve Mercer's recommendation of offsetting 2025 rates.
All right, thank you, Chicky. Do I have a second?
This is Kimberly. I'll second that. Oops, sorry.
All right, thank you, Kimberly. All right, so Dawn, how do you vote?
Approve.
Thank you. I don't believe Greg was able to join. Andy, how do you vote?
Approve.
Thank you. And Sean, how do you vote?
Approve.
Thank you. And Emily, how do you vote?
Approve.
All right, motion passes. Thanks, you all. So we are going to have to go back, I guess, 100 slides or so. And we have Kaiser here to our first carrier to present any innovations for us. I believe we have several presenters today. I show on my agenda, we've got Dr. Bachman, Dr. Melendez, Shelley Erkenbeck. Are those all the presenters for Kaiser?
That is correct. Thank you very much. Thank you very much for having us today, and appreciation to you, Siobhan, to the board, to the PEBB staff and to Mercer for allowing us to talk about innovations. I was just responding to Sean's comment, welcome back, and saying not all innovations are linked to a specific premium change. We certainly are always improving our healthcare system to improve service, to improve quality, to prefer care delivery, make it more efficient, all which will lead to affordability as well as better health and member experience. I'd also say, really, we're asked to talk about innovations, and our true innovation at Kaiser Permanente is really our 70+ year history of integrated value-based care that we continue to be on that path and doing that. But every year new things come about and we are always looking to get better. And we'll be talking about that today. We kind of twisted the ask a little bit, and we're going to be focusing on innovations in maternity care and women's health care with two really great experts, Dr. Elizabeth Melendez, who is a obstetric hospitalist and our assistant chief of OBGYN at Northwest Permanente, and our colleague Shelley Erkenbeck, who is the practice director of OBGYN, perinatology, urogynecology, and gynecology oncology. We can move on to the next slide. But before we get to the discussion of maternity innovations, I just wanted to throw out a few different things that we're doing in other domains, all that we think are important and are adding value to PEBB members that we see on a daily basis. One is working with optimizing our patient experience in specialty care, which is really redesigning our referral processes and making it easy for everybody in the system to directly book members into specialty care at the time of their visit. This is reducing days waiting for the appointment. It's reducing staff time to play back and forth telephone games, appointing people, and allows us as referring physicians in primary care and other places to really directly know which next doctor or colleague they're going to see and start a communication and start that process there. That's improved appointment capacity significantly. And we're able to get in more than 3,000 additional appointments per month and more than 500 new appointments per week. So that's been very successful. Telehealth, we've talked about that before. That's certainly ongoing to things that we're working on moving into 24 and 25 are improving remote patient monitoring. And we'll be talking a little bit more about obstetric applications of that. Also, virtual cardiac rehab program is growing, and that's been another excellent use of integrated telehealth, which has been convenient for members using better technology to improve the accessibility of virtual cardiac rehab. And finally, our e-visit program, which is algorithmically supported, straightforward presenting complaints. That's expanding as well. We've had more than 90,000 e-visits done in 2023, and PEBB members have used more than 7% of those, a little bit out swinging their weight with use of the e-visit program. One of the e-visits that we're excited about, both is the mental health and wellness e-visit, as well as a preconception visit, which is a great way to kind of start a healthy maternity journey as well. In the quality and population health arena, a few things we're excited about. One is really a much tighter system tracking people that are found to have either genetic markers or we know through other clinical reasons to be at high risk of breast, ovarian, and colon cancer, and making sure that they're getting higher, more advanced, more detailed, appropriate cancer screening. And finally, improving work with our race and ethnicity markers, which allow us to tailor care initiative, seeing which of those are most effective at reducing very important care disparities based on race and ethnicity. Next slide, please. But that's not all. A few additional things just to mention. One is in mental health, a collaborative care program, which is really sort of a structured nursing support program that with people that are suffering with moderate or more levels of depression and anxiety, making sure that they're getting frequent nurse outreaches, integrating care they're getting through with medications and with other behavioral treatments, and making sure that they're moving along and treatment is being intensified as necessary. Project Nurture, which is a program also in the prenatal space for expectant mothers who are dealing with opiate addiction issues, and then enhancing and revamping our support programs, which are really effective in addiction medicine. In the pharmacy, we are kind of using data in a more sophisticated ways to provide reminders for individuals and make it easy to help them remember to reorder their meds, providing prescription cost transparency because of some work that we did that one of the barriers around keeping people engaged in medical treatment was concerns about their costs, their ability to budget for that, and then outreaching people who it looks like indicators will be at either high risk not to refill medications or catching them really just as soon as a medication is not refilled. And then on the member side, a few things that people may notice when they're coming into clinic. One is when they're in clinic and they have the KP.org app that is on their phone and is open, that they start to get the care reminders of things that they may need to do when they're in the building. I get that every single day when I come to work, reminding me what my care gaps are because it doesn't realize I'm there to see patients and not to get my care. And then finally, as part of our social determinants of health work, we're revamping and expanding our community support hub, which is a resource directory, folks that can help people use that resource directory and ongoing social determinants screening. Or by the end of 2023, we've had 45% of our members screened for social determinants. Screening and connecting them are all part of the work. We'll go on to the next slide. And with that, I will turn that over to Dr. Melendez and Shelley.
Thank you. Good morning, everybody. My name is Elizabeth Melendez.
We did have a question, probably for Dr. Bachman. Go ahead, Sean.
Yeah, sorry, didn't mean to interrupt. Dr. Bachman, thanks for the quick overview there of those different areas. Sometime later this year, I think it would be useful to hear more about this peer support and community connection item, just for our edification. Thanks.
Noted. Thank you.
Great. So I'm Elizabeth Melendez. I am an obstetric hospitalist, which essentially means I am in the hospital for all of the care that we provide to our obstetric and gynecologic patients. I'm excited to be here today to present to you all some of the work that we're doing to provide really the safest care to our members and their babies. we on the care team see a member's health history and are able to collaborate quickly and seamlessly to connect them to the care that they need, from the prenatal specialty care to the pediatric visits. Importantly, we have family medicine physicians who participate in this care as well, which really allows for nice continuity of care for those families. At many locations, our members can save time by having routine appointments and lab testing, as well as pharmacy under the same roof. We follow our pregnant patients closely and give them extra appointments, tests, and education as needed. And after birth, we're there to help them and their babies thrive. Our comprehensive care model helps us understand the total health of that member and work towards lowering their risk of complications. When or if they have a high-risk pregnancy or a chronic condition like high blood pressure, we can tailor their care to reduce their risks and helping them and their baby stay safe. Patients who choose to breastfeed get the support they need at Kaiser Permanente to be successful. 74% of babies born at a Kaiser Permanente hospital are exclusively breastfed during their stay, compared with 51% nationally. We know that giving birth is a highly personal experience. With over 100,000 babies born each year, more pregnant people have the birth experience they want at Kaiser Permanente. The team supports choices from everything to how the patient wants to cope with their pain to which positions they want to labor in. We help pregnant patients avoid unnecessary interventions, including unplanned cesarean sections. Year after year, our hospitals have lower C-section rates compared with other US hospitals. And our care teams work together to deliver high quality care from the start of the journey to the end. We offer fertility care, early intervention for high risk pregnancies, perinatology care, which is that care that's focused on the health of the pregnant patient and the fetus, and smoking cessation programs. We also offer depression screening, care from certified nurse midwives in the hospital and in the office setting, level 3 NICU facilities, breastfeeding consultants, and a wealth of personalized support through classes and digital tools. We can move on to the next slide, please. So what we understand is that maternal morbidity is on the rise, and KP's National Quality Committee has endorsed maternal health as a national clinical focus area to improve health outcomes with the statement of Vision Zero. We will equitably eliminate preventable maternal deaths associated with obstetrical hemorrhage and hypertension within 5 years. And the reason we're focused on these two areas is because we know that those are the complications where risk for maternal death is highest. Aligning with Vision Zero, the OB hypertension program was implemented to reduce risks associated with hypertension in pregnancy and postpartum. And my partner, Shelley, will speak more on that in the next few slides. Obstetric hemorrhage or blood loss at the time of birth is one of the leading causes of maternal mortality in the US, accounting for about 12% of all pregnancy-related deaths. And Kaiser Permanente has developed a comprehensive program to prevent and treat obstetric hemorrhage that includes anemia management in pregnancy, data-driven blood loss protocols, critical event simulations, massive transfusion protocol activation, and really supporting vaginal births because we know that cesarean sections are associated with higher blood loss at time of birth. Kaiser Permanente has long been committed to improving the health of pregnant members and the communities we serve. But as maternal mortality rates continue to climb and shocking disparities in maternal health outcomes persist, with Black women 3.5 times more likely to die from pregnancy-related causes than white women. We are compelled to take bold actions and to bring our size and leadership to bear in tackling this problem. Our care teams are trained in perinatal safety, equity, and the recognition of implicit bias so that we can work towards reducing this disparity. And our members, again, as I mentioned before, are screened for depression, substance use, and intimate partner violence to see if there are ways to mitigate some of those potential complications downstream. With that, I will leave the next few slides to my partner, Shelley Erkenbeck.
Thank you for having us. As you mentioned, my name is Shelley Erkenbeck. I am the practice director for OBGYN, which means I partner with Dr. Melendez and our chief of our department for initiatives, moving initiatives forward and coming up with innovative ideas to enhance the patient experience and improve their overall outcomes. So I'll spend a few minutes talking about remote patient monitoring in OBGYN. What is remote patient monitoring? Just what it sounds like. It is really a form of telehealth that allows our teams to partner with the patient to take care of the member where the member is at and not require them to always have to come in for an appointment so that they can do some of their care from home. It's been estimated that 30 million Americans will use some form of remote patient monitoring devices by 2024. And by 2027, the global remote patient monitoring market will reach $1.7 billion. So there's a lot of ideas and attention in this growing area of healthcare. Can move on to the next slide. In our department, we have 3 very distinct programs for remote patient monitoring. We do monitoring of diabetes and pregnancy remotely, where patients have a device and they enter their blood sugars and it gets downloaded to their Kaiser, through their Kaiser app into their electronic chart. We do maternity care at home. This is for our low-risk OB population. It's an option for our low-risk OB population to do a portion of their OB visits remotely. They go home or they're taught by one of our nursing staff how to use a Doppler to listen to fetal heart tones, scale to do their weight, and a blood pressure cuff. The scale and the blood pressure cuff are Bluetooth enabled. So again, that information flows directly into their patient chart. And then we have the OB hypertension program. And the OB hypertension program is for a slightly higher risk patient population who either has chronic hypertension or who have developed gestational hypertension, either while they're pregnant or even postpartum while they're in the hospital, so that they go home with a Bluetooth-enabled blood pressure cuff that then downloads to their chart their readings. The benefit of that is, again, we're meeting the patient where the patient is at, and it allows their data to flow to us quickly so that we can act upon any abnormal results and get back to the patient. It also will send the patient a text message if their blood pressures are out of range and tell them what they need to do as next steps. Let them know they should call us or retake their blood pressure depending on what their blood pressure is. This also gives the opportunity, all 3 of these give the opportunity for the patient's family to be involved in their care from the comfort of their own home. There are partners that are been able to be part of the care, older children that have been able to be part of the process without having to bring everybody into the office for that. You can move on to the next slide. The OB hypertension program, maternal morbidity and mortality has been increasing, as Dr. Melendez discussed, over the past 20 years. Within Kaiser, about 5 to 6 percent of our members actually have a hypertensive diagnosis during their pregnancy, and up to 20% are diagnosed during labor or postpartum, which is important for close blood pressure surveillance. Without this program, patients would have to come into the office to get their blood pressure checked, which can be very inconvenient if you are a new parent trying to pack up everybody and get them where they need to go. Being able to do that at home just makes that a little bit easier on the patient themselves. You can move to the next slide. And this is just a picture of what the actual program looks like. We have them download what's called the Health Ally app on their phone. And then as part of the teaching, the nurse that does the teaching makes sure that they can take their first blood pressure successfully and have it flow into their chart. So they're verifying that the system is working during the teaching visit so that everybody knows that once the patient leaves the teaching visit, they can then do this from the comfort of their own home. And you can move to the next slide. And this is just a little bit about what our patients are saying about our remote patient monitoring programs. You can see that there is some benefit to having family involved and having family be able to help support the patient when they're part of one of our remote patient monitoring programs. It gives them a little bit more accountability. The system also reminds them if they haven't taken their blood pressure to please do so. If they've missed a few, it also sends us a reminder that says the patient hasn't taken their blood pressure in a few days. So it alerts both us and the patient if something's not working quite right. So we can move on to the next slide. All right.
Thank you, Shelley.
Go ahead.
Yeah, so getting back to this idea of vision zero and reducing our overall morbidity, you've heard how we work on that with regards to our outpatient setting and the management of hypertension and pregnancy. I want to bring us to what we're doing in the hospital. Really over the past little over 10 years now, we've really worked at improving safety and quality of care in the hospitals at both Westside and Sunnyside medical centers. We've introduced the OB hospitalist role back in 2012, and that means there is a physician in the hospital 24 hours a day, 7 days a week. We introduced training that we borrowed from our aviation colleagues to improve efficiency and communication in the hospital setting. We have worked endlessly to reduce the number of hours that our labor and delivery is on divert, which essentially means patients are diverted to other locations that are unfamiliar to them when this occurs due to staffing concerns. And so the work around reducing those hours really means we're able to provide the patients with the care that they need when they need it by the people who know them best. We've implemented standardized tactics to reduce the blood loss at time of birth and really improved our outpatient options for birth readiness to help solve for some of our bed shortage issues back in 2021. This has turned out to be a huge patient satisfier. And so those have been the focuses and the achievements that I get to brag about today are really tremendous. We've been able to reduce our divert hours by over 50%. Our blood loss or postpartum hemorrhage rate has been reduced from 12% to 6.4%, which is region and state leading. And we've allowed patients to start their induction process from home, averaging about 8 hours at home than in the hospital, which, as I mentioned before, has been a really great satisfier for them. And because of all this work, very intentional work, we were designated this last year as a best hospital for maternity care. And this was given to both our Sunnyside and our Westside medical centers, which we are incredibly proud of to be able to have that kind of acknowledgement. Next slide. So what's next for our care in OB/GYN? One of the focuses for us is the fertility care that we're offering to our patients and being able to do that in an equitable fashion. We know that there are lots of people needing fertility services and care, and we understand that there is great diversity in that patient population needing that care. One of the things that we are very proud of in our region is to be able to offer or working towards offering to patients the option for fresh sperm donation, which has previously not been allowed. And this is a really important service, particularly to our LGBTQ community. We continue to provide, again, the best equitable care that we can possibly provide, and we know that there is more work on that front to do, and we're leading that that charge to provide that care. I believe that concludes our presentation, and Shelley and I are available for any questions that any of you might have.
Great. Emily.
Yeah, thank you so much for that presentation. Amazing, amazing work, amazing results. So exciting to see that this is happening. I just had a few follow-up questions, like clarification questions. I think you're probably familiar with Oregon Health Authority's traditional health worker program and qualified certified healthcare interpreter program. And so just curious for like that earlier slide with the patient and the baby and then the providers surrounding the patient. Love seeing the paraprofessionals there, the nurse midwife, the lactation consultant, mental health support even. And just curious if there was like a traditional health worker, like a birth doula that one of our members is connected to already. Is there room for that person, that birth doula, to be part of that that care team?
Yeah, certainly. We, in fact, even during our days of COVID and managing that limited visitor policy that we had to implement in the hospital, we were still allowing the services of a birth doula to that person to come in and not count as the one visitor that we were limiting our patients to. So that is absolutely welcomed by our clinicians and physicians.
Great. And then also for a qualified certified healthcare interpreter too, that a patient or that a member might prefer, would there be room for that person as well?
So yeah, we do offer our own interpreter services to all of our patients in the outpatient and inpatient setting. And we've not, when a patient has either declined to use those services because they have their own interpreter that they're bringing with them, we've honored that request and used those services as well.
Oh, got it. And then the last question I had, just love how you're looking at the health disparities and, you know, maternal mortality specific to the Black African American people. And I was just curious about Native American as well, you know, knowing that infant mortality rates are so high for Native American babies and also Black African American babies. And, you know, Native communities won't even have baby showers until after the baby has been living for a while, because those infant mortality rates are so high. So just curious if that is on your screen for at-risk births. So yes.
Certainly. Yeah, we do look at the breakdown by race and ethnicity, and Native Americans or Indigenous peoples are included in those breakdowns. We have a very low volume, admittedly, of members that identify that way, but they definitely are part of the breakdown groups that we look at more closely to for outcomes.
Thank you. Mhm.
Great. Sean?
Looks like
Yeah, thanks so much for this presentation. This has really been helpful. You've caught us on a day where we're talking a lot about money, but I promise we don't always talk about that. We talk about health and outcomes, but it just so happens that's also what we're doing today is talking about money. So with that in mind, some time ago, so a few years, well, several years ago now, we did a deep dive analysis, and it was just like across the board. It wasn't just about Kaiser. It was just kind of like in general about areas that could be potentially cost saving related to health issues and at the same time improve outcomes because sometimes you can improve outcomes but it costs more, right? And so we were looking for areas where you can do both at the same time, and two things came up. One was diabetes, which is like clearly like less diabetes, the more you save and better health outcomes. The other actually was maternity care, and we didn't know exactly what to do with that in our data analysis. So we ended up tabling it because it was like, well, what do you do? Because you don't exactly really want to make it a goal to like have less babies, as a collective. That's not a. So we were like, well, I don't know what to do with that, so we just kind of tabled it. But it always kind of stuck to me because it was actually a big number as part of like the puzzle of cost centers and this sort of thing. So this isn't really a question, just like if you all and Kaiser could just figure this out for us and then let us know, that'd be great. It's not like that, but it's I guess it's more of an invitation later. And I guess I'm a little bit kind of looking towards like Ali here of like, I wonder if we might revisit the topic in general about maternity care, because there's clearly a lot here, and I knew that things were on a trajectory that were not encouraging nationwide, but I hadn't really seen it so starkly put in recent years, and I hadn't been tracking it past year. So that's interesting, because that's an area where we're heading, and collectively, I mean, we're heading in the wrong direction as a society, and it's more expensive. And you guys are offering a lot of support, which is great, and outcomes, but it's like there's also a cost factor as well. And so I'm just kind of like as an invitation, maybe later this year or something, to really open this as a topic that and we could kind of address lots of things at the same time, such as the health equity, because that's, maternity care is always like almost the poster for the health equity example. That's the example, it's like, for example, Black African American pregnant people tend to, have this outcome that's very different. It's the exemplar. So we could address that. It's like what can be done to improve outcomes, because we're clearly on this trajectory collectively. And how do you do this in such a way that contains costs at the same time, at least having the conversation. So I'll just throw that out there as a potential future board topic. And it's something to dive into, because last time we looked at it, there was a lot there potentially to affect both in outcomes and costs. which is potentially a sweet spot. You know, as I say, we didn't go with it because we didn't know exactly what to do. But anyway, I'm just throwing it out there.
Well, I thank you for bringing that up, because I actually think that in our efforts to improve quality and safety, we are actually saving money. I think that from the inpatient setting, reducing the number of patients who have an abnormally high blood loss at time of birth means they go home earlier, means they're not getting blood transfusions. Reducing cesarean delivery rates, again, means no operating room costs. They're going home earlier, so less time in the hospital. By looking at patients' blood pressure and blood sugars in a remote fashion, what we're hoping, we haven't seen it yet, but what we're hoping is that they're more adherent to our requests for check-ins, that they're giving us those data points earlier and more frequently so that we can identify those patients that need intervention, and we're not waiting until some terrible complication has already occurred before intervening. So I do think they go hand in hand. I don't at this point see that any of our innovative methods of improving that quality are necessarily coming at increased cost.
So I do really want to thank you for your presentation here. And as Ali said, it looks like we'll look to do a deeper dive into maternity care later in the calendar year. We are tight on time. We are going to take our 10-minute break now. And then when we come back, we'll be hearing from Providence. And I want to thank the three of you for your presentation. Thank you.
Thank you for your time.
Welcome back from break, everyone. So I do want to let you all know we're going to make a couple of adjustments to our agenda. And both David Sears from the Standard and Glenn Bailey from OHA staff will be sharing their updates at a later date. So appreciate your flexibility on that. And that will give the time allotted to both Providence and MODA for their presentations. So we are going to be hearing from Providence now, and it looks like we have Dr. Soot, Sean Isley, and Dr. Korab presenting for us. Correct?
That is correct.
All right, I will
Thank
hand
you.
it over to you. Thank you.
Okay, thank you so much, and good morning, everyone. I want to thank you for this opportunity to present to you today on what Providence is doing in the innovative space for 2024. My name is Sean Isley, and I'm the Senior Account Manager for PEBB. And today I'll be presenting along with our Chief Medical Officer, Dr. Laurel Soot, and Dr. Gina Korab, Director of Clinical Pharmacy Outcomes and Account Consultation. And you might recognize both as they have also presented to the board at previous meetings. This year, Providence is focusing on our innovation and enhancements on resources that allow our members to live a healthy life, however they define it. And our focus is on the member experience, the quality of care from providers for all members, access to care for all members, the equity of benefits, and affordability of the plan for the group as well as for the member. And to sum it up, having members receive the care that they need at the time that they need it and at the cost that they can afford. And that's a very important thing that we're looking at. Next slide, please. Oh, actually, I take it back. We can go back one slide. Okay, as we all know, healthcare can be very confusing and overwhelming for a lot of people. And what we're wanting to do is work with our members to help simplify and help members to better understand how to navigate through their benefits. And as we've stated before, our promise to you is know me, care for me, and ease my way. And this sums up what we're really working on. So this last year, we focused on the voice of the member and we built a strategy around this communication. We did reach out to those members that had left the Providence plans to ask them why was it that they left the plans. And the number one response was the required referrals on the choice plan. And the number two response was the lack of massage therapy on the statewide plan. So with this information, we did make some changes, and effective this year, January 1st, we have resolved both of these concerns and referrals have been removed and the massage therapy has been added, which was great. And we did hear a lot of great feedback from members on that. And another area we're focusing on is assisting our members in scheduling behavioral health appointments. This has really been something that I know that everyone has been dealing with for many years now because of COVID. And we want to make sure that our behavioral health concierge team has been working with these members to make sure that they're getting those appointments needed when they need to have that at the time they need to have it. And right now, the call volume is the highest that it's ever been. The good news for our behavioral health concierge team is that in January of this year, they had a really big jump on creating appointments occurring within 7 days. Trying to get in to see providers can take a little bit of time, but they really work with the members to get them in to see someone as soon as possible. Also in January this year, 27% of those appointments that were scheduled were same day or next day appointments. And this is great news and a great way to start the new year. And we are looking forward to keeping up with this momentum so that we can get those members in to see those behavioral health care providers as soon as possible. And as a reminder, the behavioral health concierge team is available 7 days a week from 7 a.m. to 8 p.m. So it gives a lot of time for members to reach out and get in touch with staff. To move on to our customer service team, it really is a collaboration between our Pathfinder team, pharmacy, bridge team, and our care management teams. And also included within this customer service team, we have 4 True Health guides or navigators specifically dedicated to PEBB members. These members are here to ease the way of members as they navigate through complex issues. They work together to remove any barriers for the member from prescriptions, clinical assistance, and finding in-network providers so that they can be seen sooner. These teams really are here to help bridge the gaps experienced by members as they seek medical treatment. So this has been something that we've been focusing on and working with members to make sure that they get that treatment that is needed. Next slide, please, Rose. Thank you. We want to let you know that we've heard you and really understand what you're saying in regards to health equity. Providence has hired Tim Shell-Tarbett as our Chief Health Equity I apologize, Chief Healthcare Experience and Equity Officer. That's a mouthful. Some of the projects that Tim Shell and her team will oversee are the NCQA Health Equity Accreditation, Enterprise Language Services, and website translation and accessibility. With the NCQA Health Equity Accreditation, it does show our commitment to our members and the communities that we serve to achieve the equitable care that we're looking for. It also does help us to create an infrastructure that really does prioritize and incorporate equity into our plan operations. This accreditation will enable the plan to better serve members across all lines of our business, which is great. And you wonder, how is this going to affect or benefit our members? We know that offering language services and provider networks mindful of individuals' cultural and linguistic needs is something that members really are looking for right now. And this also ensures opportunities to reduce health inequities and improve care. This will enable us to take a more member-centered approach by providing care for members across all healthcare continuum, make sure they're getting what they need when they need it. Another project that they're working on is the Enterprise Language Services. Providence is focusing on efforts to reimagine the language services. The goal of this project is to develop an enterprise strategy that goes beyond compliance and regulatory requirements in how we service members. Whether they need written and or spoken translation. We want to make sure that translation and interpretation services are really offered to all members and not just because of compliance or regulatory requirements. We are doing this because we believe that this is what is needed. And our goal for this program and for this process is to develop an enterprise strategy for language services, equitable language services for all members, an approach that really is driven by member needs and not solely by regulatory requirements. And we would like to establish a vendor contract that meets the needs of the Providence Health Plan. We're also working with the website translation and accessibility. This is a great project that's been going on for a little while now, translating the providence.com site into Spanish, which is in process and has a goal to be completed by Q3 of this year. And the website accessibility efforts that are underway as well. And we do expect that this will be implemented by the end of this year. So these are just some of the things that this team will be working on this year. And we expect to provide you with some great updates throughout the year. So hope to hear some really good news on the front of this moving forward. And I would now like to turn it over to Dr. Soot to discuss with you some of our new programs and enhancements. Dr. Soot.
Thank you, Sean, and I'll take that next slide. Good morning, everyone. For those of you who I haven't met, I'm Dr. Laurel Soot, and it's a real pleasure to meet you. I hope I can meet you in person at some point. I'm a general surgeon. I've been with the Providence Health Plan for the last 8 years, and before that, I spent 16 years in private practice at Providence St. Vincent's. I was on the clinical teaching staff at OHSU for the general surgery residency program. As of January of this year, I've taken on the role now as the Chief Medical Officer for the health plan. And in this capacity, I'm serving as the executive sponsor for our managed care savings programs. And what these are programs that are really dedicated to overseeing and addressing exactly the issues that you all have been talking about today, which is the rising cost of care, while ensuring high quality, effective care and treatment. And this is something I am really passionate about as we've been discussing, the best way to control costs is to keep people healthy. And when they have had episodes occur in their health, how do we get them back to the most well that we can get them to be? This is how we are going to move the needle on cost of care. And so one of the ways that we can do this is with care management. And so today I'm going to discuss our high-risk patient management programs and tell you about some new programs and initiatives for 2024. These programs, as you will see, directly reflect our mission to serve all They illustrate how we act on our promise and how much the health plan is really working directly with PEB members on our mutual priorities to address not only their medical needs, but their behavioral health needs and how their social determinants of health are impacting them and how we can really address those and drive forward to affect positively the cost of care. And I'm going to give you a very brief overview of the comprehensive suite of services that we offer within the health plan. So this is really integrated within our daily work. And then I'm going to spend the majority of my time, which is quick, to really discuss our 4 new programs for 2024. And at the end, I hope you have a better understanding of our integrated care management services within the plan, which are medical and behavioral health, how we're working within our communities that our members live in, and our consistent ability to innovate and develop new programs to address our members' needs and impact positively the cost of care as well as their health. Next slide. So care management, what is it? You know, people talk about it, but it's hard to put a finger on. And what it really is it is care that is given by nurses. So these are nurses. We have 44 nurses in the health plan who are directly engaging with members every single day. And their goal is to overall improve the quality of care and outcomes for individuals while making sure we are efficiently using our healthcare resources. They're providing education on importance of preventative care. They're including medication adherence, which you'll hear from Gina. We know that the cost of diabetes and these medications is significant. And I'm going to tell you today some of the things we're doing to improve that. So not only is it medication adherence, it's following established treatment plans, symptom recognition and management, and then other health navigation needs. So what care managers do is they navigate, they help a member so that there are not gaps in care, whether the gaps in care occur at the time of discharge, between referral from a primary care physician to a specialist, obtaining new medications, refills. So this is what they're doing. And you can see here, this is our wide suite of services. We've been #1 in the region for managing top 5 chronic conditions for many years. Diabetes is one of those top 5. And in the last 10 years, we have ranked the lowest in the region for adverse medical events, which directly correlates with cost of care. So next slide. So what's new for 2024? One of the main issues that I want you to realize as we go through this is our care management is a little bit different than other programs, and now this is very member-centric, member-driven. So many different plans, even you can have telehealth providers, different areas. What they do is something called case management. And they do a good job, but this is in isolation. So meaning that a member can have a different case manager for their diabetes or their congestive heart failure. We are doing it as a member-centric so that it's a one point in contact that our members have and a team that really knows them. And can really help drive their care in a positive manner. So we have 2 new program initiatives and 2 new service enhancements. Next slide. So one of our enhancements, we deemed this and we called it optimal aging. And this really started with our adult population, high risk, who had a very high chance of being readmitted to the hospital after discharge. It started as a pilot project and has been so successful that we've expanded it into 2024. And what it is addressing those needs of members at the time of discharge, whether they're discharged from the hospital to a nursing home to home. What we have identified is some very significant gaps that occur that then result in the patient being readmitted to the hospital. A readmission to the hospital on average for a high-risk member is $54,000. So every readmission that we prevent saves $54,000 and also improves the quality of care. And that can be as simple as identifying needs for transportation to go to the doctor's appointment, to get the medication refilled, to go to the pharmacy. So really, really important. Seems kind of intuitive, but these members don't know how to do this. And so when they don't refill their medication or they don't go back to the doctor for follow-up, they end up back in the emergency room and getting admitted to the hospital. This again has been so successful that we are now expanding this throughout the state of Oregon, also Vancouver, Washington, and including our high-risk pediatric, our high-risk maternity, and I'm going to talk about that more. I know that's been a focus, and it's a focus of ours as well, and you'll see that in an upcoming slide, as well as behavioral health. This is a real need because behavioral health issues, when you are admitted to the hospital for an acute exacerbation, the chance of being readmitted is extremely high. And so we are intervening with these members to keep them out of the hospital, keep them healthy out of the hospital. Next slide, please. So food disparity, huge issue in the United States. 1 out of 10 US households are having food disparity issues. Diabetes, which is absolutely an issue that needs to be addressed, a cost of care directly related to diet, as is hypertension, obesity, heart disease, and stroke. These are all diet-related diseases, and they're among the most leading causes of death and disability in the United States. And we also have seen with PEBB and with others that they're significantly contributing to your rising healthcare costs. Again, seems very straightforward. Better diet. Better diets are expensive. Better diets are hard to come by. And what that means is, as this picture shows, it's flavored water instead of soda. It's fruit instead of cookies or chips. It's whole grains. But if you were not taught to eat this way, if you do not have the resources for this, this is impacting your health. And so we developed internally food disparity intervention and offered it as a pilot because we wanted to do it well. 100 members. And in this small pilot, we were able to improve food disparity scores by 82%. And in a small period of time, improve nutrition scores, which is a lifelong of eating habits. Because this has been so successful and because of the need in this country, we are now engaging and navigating with Mom's Meals nationwide and other community resources for food. So again, when you take, what does care management do? Historically, they navigated members from one health provider to another. Now they've expanded and are navigating within communities to have community resources to really address these critical needs. We cannot have healthy individuals and healthy members if they do not have nutrition. It's very basic, right? Like housing. So next slide. Trans health specialization. I'm really proud to say I was the chair of the medical policy committee when this came through, and we were one of the first in Oregon to remove prior authorization for gender affirming surgery. We follow our WPATH guidelines. This is a group of members that really needs navigation. So they need somebody that walks this journey with them. It can be a very long journey when you start with medical treatment for gender affirming care, surgical treatment, what types of surgical treatment, and then there's the behavioral health needs that really go hand in hand that need to be addressed to assure that they feel fully seen, fully valued, and respected. This is a high-risk population, and as you can see, 82% have considered suicide. 56% have engaged in self-injury. And many of these risk factors are due to their environment, as well as to their social determinants of health. And we have a case management team that took this on their own. This is, again, internal, a designated team that said, I have learned what the resources are within their community. I have learned what the surgical resources are nationwide. I want to help these members navigate so they're not trying to source this and figure this out themselves. So this is a single point of contact. They don't have to keep readdressing this issue and explaining themselves, and a team that will assist them throughout this journey. Next slide. And then finally, but incredibly important. So I'm so excited to see, Kaiser addressing it. we are addressing it too. From a surgeon standpoint, I am really disheartened by the infant mortality rate, as well as we've found out the maternal mortality rate, as we're discussing as well. We are an industrialized country. We pride ourselves on the best healthcare in the world, and we have had an increase in infant mortality of 3% from 2022 to 2021. The state of Oregon, it was significantly higher. And as this graph on the right shows, and I'm sorry, some of you can't see it too well, what it shows is that the infant mortality rate increased in every demographic, with the exception of Asian non-Hispanic, in that 1 year period. What it also shows that we have been touching on is the huge disparity between different race and ethnicities. So American Indian, to the points that were made, Black also. And we can see that the differences between that and their counterparts of white, Asian, and Hispanic are significant. And because of this, again, our care management team identified this as a risk, identified that we need to proactively reach out to these members sooner. And so we could not be more excited that PEBB is really talking about how to use doulas, because that's exactly, so to Sean's point, this is exactly what we want to do. This is what we are going to do, is our care management team can help navigate with doulas, with care providers, identify those gaps and identify these members early to ensure that we're addressing these key social determinants of health and parameters that are directly affecting fetal and maternal health. Next slide. Next slide, please. So overall, I just want to thank you for your time. What we are doing for comprehensive care management support to address the things that PEBB feels is important, which we also, these are mutually important: behavioral health, social determinants of health. How are we addressing the increasing cost of care, the rising cost of medications, especially in the realm of diabetes, really getting to that point of preventing diabetes. Type 2 diabetes in many cases is preventable. But with all of this, know that this is something we are passionate about, is one-on-one support, personalized and integrated, and part of who Providence Health Plan is. So on that note, I'm going to turn it over to Dr. Gina Karab, my pharmacy colleague. Thank you.
Great, thank you, Dr. Soot. So today I want to discuss 3 important pharmacy topics across all our health plan, but specifically we're hearing from PEBB members regarding these questions. So starting with diabetic therapy care, specialty medication management, as well as cost containment strategies. And I want to share with you what Providence is doing specifically to strategize, number 1, managing costs, number 2, access to medications, and 3, innovations, solutions, and member enhancements really related to that member experience. So as you walk away from this presentation, I want you to know that we are working on ways to manage the cost of pharmacy medications for PEBB members, and we have enhancements and programs in place to do this. So if you want to go to the next slide. Oh, I'm sorry, the next one more. One more slide advanced. Thank you. So today we know that diabetes is a national health crisis in the US, with an estimated 37 million adults with type 2 diabetes and 96 million with pre-diabetes, which means they are likely to progress to diabetes. Dr. Soot discussed the importance of lifestyle interventions, food disparity, and the concept of food as medicine, and really prevention with our care management programs as really the key. And this is important because when we look at the diabetic therapy category, we see that the medication trends have increased over 40% PMPM, driven by a few things. First, the cost of medication, so the price of the branded medications. Number two, the utilization and the need for these medications, as well as the change in drug mix. To walk you through that, what that really means is we are seeing medication advancements. So we are seeing newer branded medications really aligned with the guidelines, but also with many beneficial side effects. So for a patient who has type 2 diabetes who needs treatment for medication, there is also an added benefit for GLP-1 medications for that weight loss side effect. We also know that the GLP-1s and the SGLT2s also have added benefits of heart protections for certain populations. So we are seeing that trend and that movement really in the drug mix. But we also know it's important really to design the formulary around access to medications. So our formulary is really based on a generic first formulary and really driving to those generic high value medications. We know that there's been some important changes really with legislation around insulin caps really to help with affordability, and pharmaceutical drug companies also lowering list prices. So I think good news for PEBB members. But we do know there are hardships as well, including drug shortages that have happened with changes around this market trend, as well as discontinuation of some of the important long-acting insulins. So really ensuring that we have a robust and strategic formulary really to provide access for PEBB members. If you want to go to the next slide, please. So it is important really to think about mitigating costs through focusing on this generic first approach. And one way to do this is really to maximize the value list. So I know that Andrew mentioned this before, but this is really the value list designed by PEBB back in 2010, really to provide barrier-free coverage or $0 copays for PEBB members. And these are important medications. It includes those diabetic medications, blood pressure, mood disorders or depression, cholesterol, and really encouraging and maximizing really those value list medications with additional medications to be added. At the same time, minimizing brand use. So we know that there are examples of medications that are brought to market from drug manufacturers that have similar mechanisms of actions, or really they work in similar ways with no additional value. So just making sure that we're balancing that and maximizing the value list by minimizing those brand medications. You want to go to the next slide? We also know it's important to have cost control in terms of the high cost specialty medications that we're seeing come to the market. So we have developed a robust site of care program to drive to the lowest net cost of medications, ensuring that infusible medications that have to be administered by a healthcare provider are administered at the lowest cost possible and at the most cost-effective sites. So this, number one, designing this program has to ensure access to care. So access to facilities with over 28 facilities in Oregon, clinics, standalone infusion providers, as well as a nationwide home infusion service for convenience and flexibility. This is especially important for our rural members. It also is a way to provide significant savings with $2 million saved in 2023, covering most of the medications available on the market that are required to be infused, with new therapies added on a regular basis, and at the same time negotiating best rates possible. You want to go to the next slide? We also have a key partner really with managing specialty costs, and that involves partnering with Cortina Health Solutions Specialty Pharmacy. We utilize the frontline pharmacists at Cortina to also really review medications and with interventions accepted over 98% of the time. And that includes looking at the medications from a holistic picture, drug interactions, duplicative therapies, preventing adverse reactions when possible, thinking about the dose, and minimizing waste. So these are all very important and really something that our frontline pharmacists really can help with. They also evaluate 100% of PEBB members to ensure that financial assistance is evaluated if that's possible for these members to potentially obtain that assistance, or through copay maximizer or other types of programs that may be available. At the same time, the estimated savings is $2.5 million for these interventions. So just a key partner that we are working with. If you go to the next slide, please. We also have clinical pharmacists at Providence Health Plan really working on formulary initiatives that drive to savings. And so day in and day out, we are cultivating creativity and working on savings programs and enhancements that we can really do to ensure we are providing the best possible prices as well as access for PEBB members. The results are projected savings of $17 million for 2024. And again, with that creativity and assessment, $14.6 million were saved in 2023. Just a few examples. Again, I want to highlight of the initiatives that we have been working on for many years and then adding in enhancements and solutions to include things like our channel management programs, one of the ones I mentioned earlier with that site of care, and ensuring the most cost-effective sites for administration. Formulary improvements and optimizations, really ensuring we can do anything possible to drive to generics and also get the best brand discounts as possible. Copay maximizer, and really ensuring that we're capturing any available dollars from the manufacturers. Medication and pharmacy drug-related rebates and passing those back on through to the PEBB members. Optimization of biosimilars. So I know this was mentioned as well earlier. Biosimilars are not exactly generics, but a really important strategy to help mitigate costs. And the real-time benefit check tool, which is really at point of prescribing, identifying the member's benefit with that provider to ensure that the out-of-pocket costs as well as plan savings are maximized. All of these programs are really designed to ensure that members receive the best care. They align with our providers, our primary care doctors and specialists, as well as maximizing savings to the PEBB members. And then if you want to go to the next slide, this is my last slide. And just a reminder of a program that we have implemented specifically for our Medicare population, which is an optional price transparency digital tool for members. It's called RX Savings Solutions. It is a digital offering for members to really allow them to price shop or really price compare medication alternatives. So an example could be blood pressure medications that are in the same class that might be more cost effective for a member, or lower cost alternatives. For example, cheaper medication at a different pharmacy, or maximizing benefits in terms of day supply. RX Savings Solution has a concierge pharmacy program that can really help ease members' way by answering questions, helping them process and get prior authorizations facilitated, and many other programs really to help answer members' questions. So I just want to share quickly a member experience that we had in our Medicare population, and really a comment that was received by a Medicare member. Having people look out for my best interests, making sure I know other options, takes a lot of stress off of me. It's like having a second set of eyes and making sure that I'm taken care of and not taken advantage of. What we want is to have programs available to PEBB members that provide caregivers and really members agency over their choices for their benefits. Thank you again for your time today, and I'm going to pass it over to Sean.
Wonderful. Thank you so much. And I know that we're out of time. I did want to just say thank you again to Dr. Crabb and Dr. Soot for their presentations. And as a quick wrap up, Providence, with Providence here, we're going to continue focusing on these areas that we discussed today. You know, that we've got behavioral health, health equity for all members, diabetes control, pharmacy and specialty medications, and most of all, you know, working on controlling these costs. So, you know, that is our promise to you that this is the direction we're going, and this is what we're going to be working on. And I want to thank you all for your time today, and look forward to providing updates on all these enhancements throughout the year.
All right, thank you, Providence. And yes, we are short on time. I don't believe we have public comment today. Is that right, Rose?
No, Siobhan, no
Okay,
public comment.
okay. So I just want to be sure that, we're scheduled till 12:35. If the board is willing, I'd like to extend that 5 minutes so that MODA has the same amount of time as the other presenters, and then we'll conclude.
Works for
right.
me. Yep.
Okay.
For me, perfect. Thank you.
Yes, thank you all. And I'm going to turn it over to MODA. We've got John Klaus, April Canetto, and Erica Hedberg.
Great. Well, thank you guys so much. We will try and move through the slides quickly, but not too quickly, and get us out of here. My name is Erica Hedberg. I'm the Director of Government Programs for MODA, and I brought in a couple people with me. I have John Klaus, who is our Chief Innovation Officer, and April Canetto, who is our Director of Population Health at MODA. So we're going to be talking to you about some innovations that we have implemented and provide updates on those and where we're going with those, as well as some innovations that we have on our roadmap. So the first program we want to talk about is MODA 360, and this program was implemented for PEBB on January 1st of 2021, and it was really looking to address the need of helping members navigate what we all know is the often complex healthcare system. And that complexity can really be thought of in a couple of different ways. One way is through more administrative type complexities. So for example, members might be having questions about claims, or maybe a provider billed a claim differently than what was expected, and members are having issues navigating that, or even with prior authorizations. So our MODA 360 Health Navigators are really tasked with taking that member out of the middle of that situation, because members don't do this every day. They don't really know who to call, what questions to ask, but our navigators do this every day. And so they can really take that on for the member, follow up with the providers, and then bring the member back in after they've resolved the issue. There's also another complexity of really knowing what is the best next step for them in being able to manage their health. So we have been adding on a lot of, through PEBB and through MODA, we have added a lot of really great programs into the mix that are targeted at more specific chronic conditions. But that adds a whole nother layer of complexity for members, because they don't know what Livongo is. They don't know what Strive is or CirrusMD. And so just looking at a list of available programs isn't very meaningful to members. So we really, with MODA 360, we really try and take all of the information that we have about a member and really see them as a member and try and help navigate them to the programs that are best for them and helping them manage their own health. Then next, we'll talk about social determinants of health and a new team that we have to help members address those needs. And then we will finish up with our innovation roadmap, so where we're heading. So Rose, if we go to the next slide, and I'm going to pass it on over to John Klaus now.
Thanks, Erica. So we set the stage here. We talked about some of the general themes, things that the members were experiencing or the members wanted. And so how we help them navigate through complexity, how we provide them with choice and point solutions, and then broadly, how do we improve health outcomes? How do we reduce cost? One of the main drivers there is by improving engagement, and investing in personalization is a key step to that. But one of the main contributors to improving those outcomes is having a single front door to connect to a person, our health navigator. So that kind of sets the stage for two of the innovations I want to talk about before we get into the social determinants. And we'll talk about our health context model in the next slide, and then we'll see how we're leveraging that in a couple different scenarios. So for us, this was kind of a begin with the end in mind. If we wanted to address healthcare inequity, or if we wanted to improve engagement, we really needed to shift the focus. In healthcare, it's oftentimes the case that we know everything about the patient, but nothing about the person. So what we've invested in here is a broader definition of social determinants of health. And we had been incorporating demographics and identity, a number of personal factors that help to explain the lived experience of a member, not just their clinical diagnoses. And this has been very helpful to get to know the members better. We've been streamlining the process for collecting social determinants or race, ethnicity, and language from our members. We've recently updated to a second version of the health context model, and there a big focus on geospatial determinants of health. And these two investments are going to touch on two of the themes that the board's been talking about today. One is healthcare inequity. And so if you look, inequity could occur on a number of different dimensions. It could occur along race and ethnicity or language dimensions, but it could also occur along education boundaries or income or housing instability or geography, simply living in a rural area versus an urban area. And we were talking about maternal health earlier, and this is where some of these geospatial determinants and these social determinants interact with each other. And there's an established connection between air quality and maternal health and the health and prognosis for newborn babies. And that's interesting and something we want to identify as an inequity on its own. But if you look at both air quality and income, there's a very strong connection. So we know that race or ethnicity has an effect on maternal and newborn care, but so does the environment that they live in. And so that is one of the reasons for our investment, is to be able to look at inequity on multiple dimensions, where certain area may be homogeneous along the lines of race, but could be very disparate along the lines of income or education. So in our next slide, we can talk about how we are leveraging that health context model. So the left-hand side is showing where we get our information from, how we collect and integrate a complete view of our member. And we're using this in multiple different ways. Erica talked about personalization in the opening. When we add all of these third-party point solutions, we create great avenues for people to have an ideal experience or to improve their health outcomes. But which program is right for which member? And this is a case where we've been able to leverage the health context model and our personalization engine we'll talk about in the next slide to provide recommendations for our members. And the same components of the health context model allow us to do risk stratification. So when we are looking at case management and disease management, and April will talk about our new social determinant of health advocates, how do we look at risk in not just financial or clinical sense, but also in that social determinant health context sense? And personalization also has benefits. We have all these point solutions. Maybe we have over 30 different programs a member might be eligible for. If 30 programs are broadcasting to our members, it creates a lot of noise. And so we are using our personalization engine not only to personalize the content for our members or to personalize the guidance as a next best action for our health navigators, but we're also helping our vendors to understand which members are a great fit for their program and coordinating that outreach and communication so that it isn't just a cacophony of emails coming out to every member. So I want to spend just a moment diving into the personalization engine a little bit before we kind of move on, and Erica will talk about real-time personalization going on our website and on our mobile app. So in the next slide, we've got a view here. We take for every single member a list of over 600 different attributes. And for every program, 34 plus programs right now. And we look at how do we determine the programs that are the best fit for each member. So every day we look at every program, every attribute, and come up with a list of rankings. And that shows up on our mobile app in terms of the top programs we're showing to a member. It shows up in our Health Navigators console, and it shows up to our navigators, or sorry, our point solutions and vendors, so that they have a common view of that member and those personalizations. And that kind of sets the stage for Erica to talk about the app and the web, the mobile app and the web app itself, and how we're using personalization there.
Next slide, Rose.
And I just want to call your attention to the chat. So if questions weren't answered, if you have a chance to look at the chat, that'd be great. Thanks.
Great. Thank you. And so John just got done talking to you about pretty much the magic that happens in the background. And I'm going to just show you what that looks like and how it gets presented to the member and what the member experience is around that. Because it's great to have all of this data, but you also have to bring that to the member as well. And so one way we do that is through our member dashboard. And this is just a screenshot of the top part of our member dashboard. And when members log in, they're going to see those top 3 personalized programs over here in this tile that's labeled Moda 360 programs. So for this member, I know that this member is a type 1 diabetic, and we know that depression and diabetes oftentimes can interact together. So this person, we have recommended for them mental health support with Spring Health, which is the virtual behavioral health provider that we implemented for PEBB 1.1 of this year. We have Maru Health, which is a point solution that helps members with anxiety. And then we have our Comprehensive Coordinated Care Program, or C3. And this is a program that waives cost sharing for primary care visits for members who are some of our most at-risk members. And it's really helping them be able to access the healthcare system and get them engaged with high quality primary care. So this is what a member would see when they come into the member dashboard. If they click here to go look at the programs, so Rose, next slide, they're going to come to this screen over here, which is in the top left. And it's always going to have our personalized programs up at the top. And then underneath, it's going to start listing out all of the different programs that we have for members. Members can also search by over here on the left under category. There's lots of different categories they can search by. So maybe they want to see all of our behavioral health programs, or maybe they're interested in fitness programs. So they can click through there. The dashboard will only show programs the member is eligible for. So for example, if the member is not a diabetic, they are not going to see any of our diabetes programs because they're not eligible for them. But the programs that they are eligible for, like this C3 program here, those are going to show up for the member, just to really help the members get connected to the right programs and not spend time looking at programs that are not applicable to them. When a member clicks into the program, right here, you see this box. This is Spring Health, which is that virtual behavioral health network that launched on 1.1 for PEBB. It gives them a little description of what that program is. And then they can click on the blue button, and that's going to take them to the PEBB Spring Health website. We also want to make it easy for members to download the app. So here they can click on either the Apple Store or the Google Store, and it's going to take them right to that App Store and that app so that they can easily download it. Next slide. And another way that we make it easier for members to engage with the programs is that we recently launched an app for Moda 360. And this has all of the same functionality as our dashboard. So it will have the personalized programs that we've been talking about, as well as care alert notifications. And those are preventive services that members may be behind on. So for example, if they haven't had their teeth cleaning for the year, that'll show up as a care alert. And the app has notifications that will push out to the members. We understand that we don't want to overload them with messages, so we keep the messages meaningful. And those alerts will be either the care reminder, or it'll also text or message out the top program for that member. So you can see here that this member's top program was the C3 program. Great. Next slide, Rose. And as John mentioned, we take all the data that we can and gather on the member, and we use that for personalization. But we'll also be launching a self-guided assessment this year that will actually walk members through a series of questions, and it has branching logic. So depending on how they respond to, certain questions, will determine what other questions come up. This is an example of the self-guided assessment that we have for our Behavioral Health 360 program. And I know PEBB doesn't have that program, but we'll be launching this one for all of our programs this year. And so it just asks questions. It'll have a lot of SDOH questions in there. It'll also have screening for like the PHQ-9, so for anxiety and depression. And then after a member goes through and answers all of those questions, then it will give the member in real time the suggested programs for them. And then that data that's collected feeds back into the health context model and then the personalization engine that John discussed earlier. So it's really just another way to get to know our members better and be able to offer up the programs and the best steps for them. All right, so next slide. Right, I'm going to pass it over to April, who's going to talk about our SDOH team.
Thank you so much, Erica. Hi, everyone. I'm really excited to talk to you all today about some of the innovation that we're building in, really as a way to continue to leverage the work that John talked about and have really proactive strategies in place to support members across our population health pyramid. So some of the work that we've really been doing based on the information that we've been getting back from Health Context is to really understand where do we have opportunities to continue to build out our pyramid and ensure that we're supporting members across all levels of acuity. And so one of the levels that we've recently added in is our social determinants of health level. And as you can see, it's towards the base of the pyramid. And the reason for that is that as you go up in the pyramid, it's the kind of the proportion of individuals that would be eligible for a program based on current risk profiles. And so what we can see is that when we look at social determinants of health, we have a lot of opportunity to not only use the data that John was referring to develop and support members with our personalization approach, but also to use it in a really active way to help members and meet them where they're at. And so if you can go ahead and go to the next slide. We have built out our SDOH advocate team, and this is something that is not yet live. It will be live in Q2. And so what we're doing is we're really taking that data, as I mentioned before, and looking at the different indices, if you will, around social determinants of health. So where members need support around things like economic stability, health and healthcare, education, and using that to actually conduct proactive outreach to members and support them with doing more intensive SDOH assessments and then connect them into community resources while developing an SDOH targeted care plan. And so there's multiple ways that this SDOH advocate team will be supporting members. We'll be using lists that are going to be generated off of the personalization work, using health context to identify members who are at risk for needing SDOH support. Additionally, members can be referred into our SDOH team through our health navigators, through the console they can self-refer, through all of our different vendor partners. A large part of our referrals also will be coming in through our programs like our case management and our disease management programs, so that we're able to really form that full care team and have specialized individuals and teams that really support that SDOH domain. You can go ahead and go to the next slide. And so the way it works is once we've identified members either proactively through risk stratification using the health context scoring and/or through referrals, then we conduct outreach. We then enroll the member in the program. We do in-depth SDOH assessments. We actually set very targeted care plans around SDOH, and we create all of these within care teams. So if the member is enrolled in any of our other population health programs, all this information is shared across the team. And then we actually leverage our Unitas platform. So we're able to then layer in additional independent support beyond Unitas to really identify what community resources would be able to assist the most with that member, and then support closed loop referrals into those SDOH programs. And then follow back up with the member, continue to iterate their care plan, and ensure that they're getting the scope of resources needed to fully support their SDOH needs. Go ahead, Erica. I think that was my last slide.
I think if you go, I have one last topic that I'll use a couple of slides just to tee up maybe a future conversation. So in under the scope of innovation, we've been investing in artificial intelligence, generative artificial intelligence. And I think what we need to do today is set the stage for that and perhaps have a follow-up conversation in the future. That the most significant thing in terms of framing up an AI conversation stems from rate of change. If we go back to 1998, it took about 18 years for computers to come up with the ability to interpret speech at a human level of comprehension. It took 15 years for computers to have a human level of handwriting recognition. It took only 6 years for image recognition. It took only 3 years to be able to read and comprehend written language, and 2 years to understand the nuance of language. And in 2017, two things happened that really kind of changed the stage forever and led to the current ChatGPT phenomenon. The first one was an exercise by Google and their chess learning algorithm AlphaZero. It took around 4 hours for AlphaZero to start with nothing but the rules of chess and become the single best chess playing entity, computer or human, on the planet. And at the same time, companies like OpenAI and other pioneers in generative AI had both the resources and then the awareness of how much data it takes to train one of these large language models. And now I think there's a couple of key takeaways. The first one, when we talk about artificial intelligence, what was absolutely impossible 5 years ago has become a commodity feature. That's general. I think in specific, in terms of healthcare, in healthcare, there's two kinds of data. There's structured data, like a blood pressure or heart rate or respiration rate, things that are numbers that are stored in data warehouses. And the other type of information in healthcare is unstructured. It could be a handwritten note or a typed note in a chart. And the amount of information